Hello guys, we are back with the next part of the lecture. Now this is about pacemaker safety. Now we call them cardiac implantable electronic devices, and there are three types of them. So there are three categories of these cardiac implantable electronic devices. The first one, we just call them loops, but also known as implantable loop recorders and insertable cardiac monitors. So these are basically for targeted ECG monitoring to look at if there is any arrhythmias, if there is any sensor rhythms, which are not usually seen at one-point ECG recording. Then we have the cardiac pacemakers, which can be single lead, where we have the pacemaker generator, which becomes the negative port, and then the pacemaker electrode wire, which is in the right ventricle. Or they could be dual lead, which could be atrial sensing ventricular pacing, or atrial pacing ventricular pacing, or atrial pacing and ventricular sensing, or they just could be atrial and ventricular sensing devices. So there are two leads, atrial and ventricular leads here. Or you can have biventricular, cardiac pacemakers, where there is a lead which goes to the ventricle as well. This is placed through the coronary vein, and that can again be to the left ventricle. So you have leads for left ventricle as well as right ventricle, and there's obviously a right atrial lead. Then the ones which are a lot of concerns for any anesthetist is the patients who's got implantable cardiac defibrillator, or ICDs as we call them. And again, these can be single lead, dual lead, or biventricular. So usually have a superior vena cava shock coil, or right ventricular shock coil and right ventricular shock coil. And then there are some newer kind of pacemakers, which are not as popular. Then you have the SICD. So there's a system where you don't have to go through the venous system. And there is just a subcutaneous, S stands for subcutaneous electrode system. The pulse generator is actually placed just under the skin, like for a normal pacemaker unit. And then we have the leadless pacemaker. These are just like capsules. Again, just left. There's no wires. There's no unit pacemaker unit in that. And this will transmit data through Wi-Fi system wirelessly. Okay, you can see that in the X-ray in the red circle on the right side. So there's a whole range of newer pacemakers, from loop recorders, the permanent pacemakers, then defibrillator ICDs and subcutaneous defibrillators. So pacemakers are normally used for control of bradycardias, whereas the ICDs are normally used for treatment of life-threatening ventricular tachycardias. And the biventricular or resynchronization pacemakers and ICDs, these are becoming more common in patients who have had heart failure secondary to any reason. It could be just post-MI. And these are known as ventricular resynchronization. And if they are pacemakers, they call CRTP. And if they have defibrillator as well, and they're CRTD. So the P and D are basically for pacemakers and defibrillators. This is a CRT Medtronic device. The other one is from the Boston Scientific. You can know that there are three leads. So you have the atrial lead and two right and left ventricular leads as well in there. So what happens if you see a patient who has pacemaker coming to the pre-op clinic? The first thing you have to ask, does this patient have any of these? And you contact the physiologist or the pacing or ICD clinic at the hospital, where the patient normally goes. You tell them the patient's details, the day of surgery. If the patient has an implantable loop recorder or the loop, then we need to know if this has been recording some kind of arrhythmias, which could be significant. So we need to follow up with the results and escalate accordingly. If the patient has a pacemaker or ICD, then you need to know when was the device last checked, and is there, is the patient due for another check? And this has to be documented in the notes, along with the name of the physiologist who has done the check or where it was done. Now, if there is a check overdue, or there has been a device problem, or the patient is followed, somewhere else, then you need to then arrange for a check for this patient, which sometimes can be arranged locally if there is details of the pacemaker or the device is available. And the consultant anesthetists who are going to anesthetize the patient need to be informed. Now, if this is an ICD, then it becomes a little bit more complex, because the theater list should include this information. The anesthetists involved need to be told that a patient with ICD is coming onto the list. You need to inform about the where the check will be done, or you need to inform your the physiology lab, cardiorespiratory lab. And it need to be sure, you need to make sure that the device has been checked within the 6 months. And if it is not, then you arrange for these checks. The patient should be first on the list, and the reason being that, like, for example, our cardiophysiologists, they work only from 9 to 4. So it's better to get the case as done early in the morning, and so that they can come and reset the whole thing, because the pacemakers need to be deactivated when the patient goes to the theater. Once the ICD has been deactivated, the patient need to be monitored till the time patient actually reaches the theater. For pacemaker, if the TCI date is not within 12 months of the device check, then you need to arrange for a new check and restart the whole process. On the day of the surgery, if the device has been working fine, they have been recently checked, you just follow the standard precautions. When using diathermy, use bipolar wherever possible. And if you're using monopole, use in very short bursts. And you need to monitor any changes on the ECG. And once the procedure is done, if there have been no problem at all, there's been no ECG changes, or you don't expect any problem, pacemaker need not be rechecked again. But if the diathermy was applied directly to the pacemaker and accidentally, or because the surgery was near the chest, it was a breast surgery, or it was surgery, thoracic surgery, cardiac surgery, or there have been inappropriate pacemaker function during the surgery, in that case, the checks are required. So this is the whole flow chart for ICD. So patient attending the pre-op clinic, pre-op assessment. Does he have a loop pacemaker ICD? No, then that's not an issue at all. But if the patient has got these, then you need to contact the physiologist in the pacing or ICD clinic with the patient details and where the patient is going to have the operation. If it is a loop recorders, you need to arrange for pre-loop device being interrogated, find out if there's any arrhythmias. If there's nothing, that's fine. But if there's anything sinister or suspicious, then you need to inform and escalate it further. If it is an ICD or pacemaker, then you need to make sure that it has been checked recently. It's within 6 months for ICDs, 12 months for the pacemakers. And if it is check is overdue, make sure that the patient is only listed after the checks have been done. For ICD, it's important that the anesthetist involved is informed, the theaters is aware of it, the physiological lab, cardiorespiratory lab is informed, and a check is arranged in the morning because for deactivation, and again, that it'll be required reactivation at the end of the surgery. And if it is a pacemaker, again, like I said, if it is within 12 months check, that's fine. You can proceed with standard precautions. And if there has been no problem intraoperatively, there's no need to recheck the pacemaker at all. So when you have a patient who has got a pacemaker or ICD, you need to also check, what type of device it is, where was it implanted, where was it followed up, when was the last date of check, is the device reaching a replacement date, where is the device located, is it in the right infraclavicular or the left infraclavicular fossa, are there any restriction, is it been implanted as part of clinical investigation, for example, is it a CRT device used for the cardiac failure patients. And follow-up clinics will usually be able to confirm whether they are correctly functioning, what is the condition of the battery and leads. They can advise whether they require any changes to the parameters, sensing and pacing parameters, or if it need to be reprogrammed or switched off or put into a asynchronous mode. So the pacing unit, the communication with the pacing lab is very, very important for you. Other pre-procedural support we require is that ECG need to be monitored from the outset, and the pacing mode need to be turned off. Not every ECG machine will automatically detect the pacing spikes. You have to go into ECG setting, and then you need to click on the pacing, that the pacing is on, and then you will see the spikes. Otherwise, you won't see it. It looks like a normal ECG if the pacing is not on. So that's very, very important. You should have facility for external defibrillation, external pacing should be available, whether it's a transvenous or transcutaneous pacing. It doesn't matter, but you need to have that facility there. And in patients who have got ICD and limited access to the chest, if, for example, the surgery has been done on the breast or it's a cardiothoracic unit, then external pads should be attached before the surgery, and make sure that they don't get detached because of the cleaning or asepsis solution which is used. So make sure that these facilities are available to us. Now, intraoperatively, if you detect any pacemaker inhibition with the use of diathermy, you need to inform the surgeon, ask them to use diathermy in short burst or discontinue altogether, or maybe use a different kind of diathermy, like the ultrasonic one. The harmonic can be used. And in case of device program is altered, you continue to monitor till the end or till the setting is restored. So sometimes these changes are not permanent. They can revert back to normal. But if you suspect anything, then you need to get the cardiorespiratory unit involved. They will come and interrogate the pacemaker and reset it. Or if there is been damage, there need to be things may need to be changed. One of the most important interference which can happen is the electromagnetic interference from the diathermy, which can lead to inappropriate device function. So there are special filtering components within the pacemaker. There is better shielding, there's protection against that, but still they can happen. And why is this a concern? So pacemaker interference can occur despite the filters, and this can happen because the diathermy is very close to the pacemaker unit, so it is kept very close. So the pacemaker is on the left side of the patient, the infraclavicular, and the machine diathermy is very close to it. You're using very high frequency, high current, and this can cause radio frequency. Within, even despite having a good shielding. The shielding is for the pacemaker unit itself, but interference can happen in the your lead, through the lead. Okay. And what can this kind of interference do? They can inhibit the pacemakers because they sense as if there has been tachyarrhythmias, and they will actually just inhibit. Or it can induce a fixed rate pacing. That is mostly not a problem because it reverts back to normal as soon as you take away the interference. But the dangerous thing, if there is a software reset, which is again not very common, but in patients who might have ICD, now we're not ideally it should be switched off, but if it has not, it can trigger shock in a patient. So these are the few things which can actually go wrong, like say inhibition of pacemaker, fixed rate pacing, triggering of shock in ICD, reset of software. All this can happen despite, the pacemaker you've been shielded or have a good protection against radio frequency. So is the EMI effect permanent? No, it's not. It's a transient. Device will set back to normal when interference ceases. Okay. But permanent effect can occur in situations where there is a very strong, very powerful field like gamma radiation, or very strong magnetic field like the MRIs. We wouldn't want to take a patient with ICD to that. Okay. So ICD, as we said, is used for treating ventricular tachycardias, ventricular fibrillation, and EMI can be misinterpreted as ventricular arrhythmias and lead to inappropriate shocking and lead to activation of antitachycardia function in that. So diathermy are dangerous machines for ICD, and that's why the ICDs need to be deactivated before patient is taken to the theaters. Then there are various sensing parts within the pacemaker leads, and these are known as the impedance-based rate responsive pacing function. So what these do is they sense when you're breathing, your chest expands, isn't it? So it will sense the distance between the tip and the pacemaker unit. The more rapidly you breathe, that means you're using more oxygen there, it will increase the rate. So like in exercising, your minute ventilation will increase. They will sense this increase in a minute ventilation and accordingly change the response of the pacemakers. So these can be damaged. If these are damaged by diathermy, then the whole unit has to be changed. Okay. So what do manufacturers advise for implantable pacemaker and ICDs? They say it's contraindicate use of surgical diathermy or electrocautery. So they say they avoid as far as possible. And they give strong warning against its use, especially, monopolar, unipolar, and the most common use. I mean, they would say don't use diathermy at all if possible. That's what the manufacturer's advice would be for these units. So coming to the loop recorders, usually there's no special precautions required. You have interrogated it, it's fine. That don't worry about it at all. Now coming to pacemaker and ICDs for specific surgeries. Now for ICDs, whether it's a surgery on the head, neck, chest, doesn't matter. They have to be deactivated before surgery and reactivated immediately post-op. So that's common for everything. Now coming to the pacemaker itself. Now if you're operating very close to the unit, pacemaker unit, like head and neck, or using abdomen, upper limb, elbows, then you might consider reprogramming the unit, putting it into a fixed mode, because every time you use diathermy, the radio frequency can affect the setting on it, or the current is flowing directly through the lead. So you don't want that. But sometimes if you have reset it to fixed mode, then it can come back to its normal, or it needs resetting back to normal. But if there has been no changes in the pacing, or intraoperatively you not notice any problem with the programming, then no post-op checks are required. Now that is something very new, because previously the guidelines were that you use diathermy, the patient have pacemaker, you need to get a check done. Now the thing is, it's saying that, okay, fine, you can use diathermy, but if you do not notice any changes, and this is because the pacemakers have become better, in a sense there is better shielding and better protection against all these interferences. If you're operating on the lower abdomen, lower limb, or the upper distal limb below the elbow, it says no reprogramming is required at all. And there's no need to have post-op checks if there has been no alteration in the programming or any adverse events. Cardiothoracic, the current is going to flow through that, so reprogram is highly likely. So you need a full post-op check. ICDs, like I said, they need to be deactivated. Ophthalmic surgery, you're working on the eye, you're working in a very small area. They hardly use monopolar. I don't think they ever use monopolar for that matter. And they need to, it is close to the eyes, maybe close, especially if the pacemaker unit on the left side and you're operating left side eye, then ask the surgeons to use diathermy in the short burst. It's a bipolar, obviously. And if there have been no changes in the rhythm, there's no need for a post-operative check. Endoscopic procedures, again, you monitor them during the procedure. There's no requirement for changing any settings on this, and there's no need for post-op checks at all. Dental surgery, they hardly use diathermy. Again, they use chemical cautery. That's what is my experience. And so no need for any checks at all. Lithotripsy, usually the kidneys, left side kidney, if it has been, there is a stone in the left side kidney and the beams are focused very close by, maybe you will need to interrogate the pacemaker, after some time. I don't know why this 1 month is used, but if you notice anything, you got to interrogate it, otherwise not required. And ICDs, again, you need to deactivate before surgery and reactivate it again. ECD, again, general measures need to follow. I mean, they're applying current to the head. And again, you don't need to reset it. You can interrogate after a month or so. But ICDs need to be deactivated like any other surgery. Nerve conduction studies, EMG, we are not normally involved in those kind of procedures, but general measures need to follow. And if the conduction studies are on the same side as a pacemaker unit, maybe you need to have it reset. But again, the stimulus use is repetitive. It's not a continuous stimulus use. So usually don't require any post-op checks if there has been no changes in the rhythm at all. Radiotherapy and pacemaker and other things. This is very important because here, both the pacemakers and ICDs, they can sustain injuries. I mean, the units from the radiotherapy, they're using very high energy gamma rays or other rays, and the functions can be affected by radiation therapy. The radiotherapy beams can damage the batteries or the circuit and cause malfunction. So in these cases, you need to make sure that the pacemakers are put on to a asynchronous mode, and you need to again interrogate the unit after the procedure. Unfortunately, there are no detailed national or international guidelines or consensus about this radiotherapy. So these are special kind of patients where we need to be careful with the use of diathermy. Now, coming to emergency procedures. Now, if a patient comes in the emergency, you don't know what kind of, they go to pacemaker unit, you don't know whether it's a pacemaker or ICD. You just need to follow the ALS protocols as you would normally do. Chest compression, cardiac arrest, just good CPR as normal. So if a patient has got a, ICD, even if it's delivering shock, it's not going to get transmitted to you. So continue doing CPR as you would normally do. And if resuscitation is successful, you can integrate the device after awards to see if there has been any damage to the defibrillator, where it's been constantly shocking, or they need to get changed later on. If you have to apply pad, it depends. If the pacemaker unit is on the left infracollateral fossa, then you can have pads on the right infracollateral fossa and the apex. But if the pacemaker device is on the left side, then make sure the pad is below. It's not over the device. Okay, so otherwise you'll cause damage to the device. Okay, anteroposterior are actually better when you have pacemakers. So you have the first unit at the apex and your negative one at the back. So next one is about magnets, and this is important topic. What do magnets do to pacemakers and ICDs? So if you actually place a magnet over a pacing unit, what would actually happen? So that's a magnet what we use in our setup. So a pacemaker will respond immediately to when you put a pacemaker on, but the response is temporary. So as soon as you take away the magnet, it should resume back as soon as it is removed. This goes back to its normal setting once the pacemaker is there. So when you put a pacemaker unit on, a DDD is changed into a fixed mode, DOO, or VY to VOO at a preset magnetic rate. Now the magnets were used to extend the battery life. So if the pacemaker unit is set to have a fixed rate of 85 per minute, but when you apply magnet, it's only setting at 60 rate per minute, 60 beats per minute, that means the battery needs to be changed. So where do you actually apply the battery? The magnet. So it's recommended that you should hopefully not need to have the magnet applied on the pacemaker unit permanently, because asynchronous mode, it sets in asynchronous mode, but it can be arrhythmogenic as well. You can still have R-on-T phenomena when you have the pacemaking unit. Okay. And like I said, magnets were used or are used to looking at what is a battery status. As the battery get depleted, the fixed rate will go down. So magnet response will persist as long as the magnet remains close to the generator unit. So if you want to use it for a long time, you need to tape it to the unit itself. And every pacemaker unit is different. So if you got a pacemaker which is from Medtronic or Boston Scientific or Biotronic, you can apply the magnet directly on the whole unit. But if the pacemaker is made by St. Jude's, it needs to be applied on the header. That is the top end of the pacemaker. You don't apply it over it completely. You need to apply it on the header part of it. So don't apply at the lower end. Or you can apply at the lower end as well. Sorry, upper or lower, not the complete thing. Whereas if you look at the LivaNova pacemakers, these were from initially known as the Sorin. They were formerly known as Sorin. They were bought over by LivaNova. And then it says that you avoid the header, the top end. So it's always the bottom end, which has got the reed switch. So you apply to the lower end of the pacemaker and it'll go into a fixed mode. And if you need to use it throughout the operation, then you secure it with a tape, because otherwise if you remove it, it goes back to its normal function. Some of the ICDs, like the Biotronic one, they will revert back to its normal after 8 hours, despite being constantly kept. So what you need to do, take it off and reapply it again. So then you can use it more than 8 hours. What do you do if the subsequently patient goes into VT or VF? Just follow the ALS guideline. You just start your compressions. You might need to use external pacing for these patients. Okay. Thank you. Thank you for listening. I will stop sharing now.